Welcome back to Reframe the Future, where we continue to speak with change makers right the way across the health landscape. We're going to look at the directions of travel for the industry and assess where the greatest impact lies. Today's guest is Wayne Bateman, who is a behavioural scientist that's worked on shaping behaviour change campaigns with Public Health England, as well as UK local councils, with the aim of nudging specific audience demographics to improve their health and adopt healthier behaviours. And I'm joined by my Aurora colleague, Will Brennan, who works on some of the agency's biggest campaigns and also leads on driving measurement in communications.
Hi, Will. Hi, Seb. Nice to meet you both, and thanks for the invite.
Hi everyone, and I'm very excited to be here and looking forward to finding out more about inspiring behaviour change campaigns, how we can plan better and put behavioural science at the heart of our work, and especially how measurement can evolve to work better with behavioural science. So I think then to kick us off, it would be great to know, Wayne, a little bit more about the health campaigns and interventions you've created, sort of both with Public Health England, but also with the UK's regional councils, and also, what were their aims and how did behavioural science in particular drive change?
I'd say the most significant project I worked on was around vaccine uptake. So when the COVID vaccine was released, there was almost like a general assumption that everybody would just run and get the vaccine. But actually, as a behavioural scientist, I was curious as to whether that would be the case. So I did some research looking at uptake of other vaccines, for example, like MMR, and also other vaccines for previous pandemics. And when you look at it, actually, there are certain groups within our population where uptake of those vaccines is significantly lower than other groups. And so I did a big piece of work, which was helping also guide implementation of vaccine rollout across local governments, which was about engaging with the public and really understanding, okay, we've got general population, we need to reach herd immunity, which was around 80%, but the risks are there are certain groups who aren't going to come forward and get the vaccine. And so the research was focused on who are those groups, what are the barriers. So it's a key part of being a behavioral scientist is specifying your behavior. So in this case, it was uptake of the vaccine, and then doing a behavioral diagnosis. So really understanding, okay, what are the barriers and enablers for different groups across society, because not everyone's the same, regarding having the vaccine. And then when you identify those, as we did with the research we did, developing interventions, many of which are comms, so healthcare comms, to address those specific barriers in those specific target populations. And then alongside that piece of work, which lasted about 9 months, I'd say, I did a piece of work on engagement. So as we'll probably discuss today, at the core of behavioral science is engagement, and that's engagement with internal stakeholders, but actually most importantly, the end user. We identified 5 barriers to having the vaccine across the general population. So they were how at risk I believe I am. And it's important to point out it's a belief or a perception. It doesn't have to be based in fact. So my perception of how risk I am of getting COVID, my perception about how severe it would be to get it, and then 2 around the vaccine, my perception of is it safe and will it work, and then the convenience. So generally those were the barriers for the COVID vaccine uptake across the general population. But then based on the research we identified within some groups, there was a barrier of distrust in the government. In other groups, it might be there was fears around the health implications. And so then what we did was to work with those groups in particular, where those barriers have been identified, really take the time to understand the barrier and then develop interventions, whether it's comms, for example, with those people themselves. The best way to do it is also to take an iterative approach. So as you're out there and you're engaging, so if it's frontline workers, healthcare practitioners administering the vaccine, as they're coming across certain barriers and reasons given by people, to feed that back so that we then become aware of it and can design, if needed, an alternative intervention to address those.
So just a follow-up question to that, Wayne. So I think just given the unprecedented nature, I suppose, of the COVID pandemic, and especially in its scale, did you have any sort of frameworks or any previous experience to draw on when it came to sort of addressing it? You mentioned that you worked with faith groups and community leaders. Is that something that you had previous experience of doing?
I guess the difficulty with COVID was typically within a behavior change program, you'd have a piloting or a testing phase. So once you understand the problem, you've identified the barriers, you developed your theory of change, you build interventions, and then you pilot them. Before you roll it out, you take a sample say, for example, we were going to do it to 1,000 people, we might sample 100, you trial it, did it work, make some changes, roll it out. But with COVID, everything was so quick. We had to respond very, very quickly, and rightly so. So in terms of, for example, like the campaigns we had with faith leaders or community groups where we were co-branding, we were doing some evaluation on the ball. So as people we'd identified within the community were delivering these messages, we were gathering feedback from them, but it was in real time, so to speak. It wasn't a case of, okay, we'll try this with 5 or 6 and then roll it out.
And just to sort of unpack that a little bit further, because I guess as healthcare agencies, what we do, day in, day out, is really kind of identify key audiences. We then look at kind of messaging and the appropriate media channels to deliver those messaging to the right people, whether they be social, digital channels, more traditional media channels. Obviously, things like social and digital offer us the chance to really hyper target very specific, nuanced messages to particular audiences. But I guess just in terms of sort of some of the principles of, baking behavioural science into the campaigns that we do, very regularly with our clients, what are some of the things that we should be doing to put behavioural science right at the heart of more of the campaigns that we do?
So if you look at behavior change, the key to effective behavior change is understanding the behavior. And if we think within a health context, there's a wide body of research that shows just providing information on a particular health behavior doesn't get people to do it. I might think, okay, I need to be healthy or fitter. I know what to do. Do I do it? Okay, so now as an agency and as targeting a particular population, you need to know what are those other influences and what are those other factors. Some of them you'll have some influence over, and so education, for example, is one way to intervene. Others you won't, but an awareness of that is key. And then an awareness of those that you have an impact over and don't is thinking, what's the best, so you mentioned like channel, what's the best channel to reach them, but also what's the best content for it? What's the best, for example, images to use or the call to action? Who's the best person to deliver the message? So one thing we know about behavioral science is the messenger is key. So it's not just about the content, it's who that message comes from, and evaluating changes in behavior. So as behavioral scientists, what we're interested in is actually, did we affect a change in behavior? And how do we measure that? How do we assess that? As opposed to, did we observe or did we see a change in intention to behave differently? Because we know that there's often a wide intention behavior gap. And there are things that we know from behavioral science about how you can address that and encourage people and support them, whether it's an individual level or a social level or environmental level, to carry out that behavior.
So from your perspective, Wayne, when are some of the sort of, key behaviour change models most appropriate to implement? Things such as COM-B or BMAP, and are there any sort of key considerations from your perspective when looking at which one you're going to use sort of over the other?
Even though behavioural science is in its infancy, in some ways, there are already tried and tested models and frameworks. So, for example, you have the Behavioural Insights Test Framework, which is about behaviour change as a whole, so targeting and identifying the behaviour to designing solutions, implementing, evaluating. But then within each of those, and you also have the Behaviour Change Wheel by Susan Mickey, within each of those, you have an aspect which relates to what you said about the COM-B and the BMAP. So it's a behavioural analysis. So when you've identified the behavior that you're interested in, whether it's a behavior you want to happen or not to happen, and you've identified the target group, so who is it specifically, you would ordinarily do a behavioral analysis. And so at that point, I might have a number of different tools, the two you mentioned being the COM-B, so Mickey et al., as part of the behavior change, the other one being BMAP, so the FOG behavior model. In terms of both, you can apply both of them. And actually, there's a great overlap in most of them. So the COM-B, I guess the premise of that is for a behavior to happen, you need to have the capability, opportunity, and motivation. The FOG model, so the BMAP model, for the behavior to happen, you need to have the motivation, ability, and then like a prompt. So the key difference there, I would say, is the COM-B is a far more detailed and broader behavioral diagnosis tool. And so you can use it for really complex interventions. the BMAP, I would say, is still relatively broad, but there's a greater focus within that one on prompts or nudges. So what can you do to prompt somebody to do a particular behavior? That's not to say that it doesn't exist within COM-B, but the emphasis is it's not as emphasized. So if I was looking to do a more complex behavior change, I might do COM-B. When we were looking at COVID, all the behaviors we were looking at there, we used COM-B. If I was looking at, say, for example, I've got a digital platform and I want somebody to do something different, and really all it requires is a little nudge to get them to do it, or a little reminder prompt to get them to do it, I might use the BMAP.
As you say, Wayne, the kind of application of behavioural science is very much in its infancy when it comes into communications, but we are seeing some really good examples out there, and some high profile examples of where that thinking has been baked into the creative, the insights, and all of the kind of execution material. So, one of the campaigns that has been very high profile was the Mayor of London's "Have a Word with Your Mates, Then Yourself" campaign. So, that looked at addressing sexist attitudes and inappropriate male behaviour, but actually really clearly demonstrating what the sort of social norm should look like. So rather than sort of focusing too much on what you shouldn't be doing, I guess the advert really kind of effectively communicated this is what a social norm should look like, and how men should be behaving when these situations arise in social situations.
So we know within behavioural science that if you want somebody to do a particular behaviour, you need to be clear on what that behaviour is, and telling somebody, okay, don't do that behaviour. In a way, you have to give them alternative. And so, for example, there were some projects I'd worked on, again, related to COVID, but more around sustainable travel. So during COVID, people were starting to walk and cycle more. And what we wanted was people to maintain those behaviors after. And so that was about communicating, okay, don't return to traveling in your car to work. Why don't you carpool? Or why don't you get public transport? Or continue walking and cycling, and then also bringing in, which somewhat relates to what you were saying, the social element. So, saying things like 70% of people in your area walk or cycle to work, or when we've done work with schools and trying to encourage parents to walk their children to school, we might use a social norm to say, 70% or 80% of parents are now walking their children to school, because we don't, as individuals and humans, we don't like to feel like we're part of the minority, particularly if there's a negative associated with that. And I think maybe another link is, so I used to do some work on bullying interventions within schools with Professor Ian Rivers, who's probably one of the leading in the world in regards to bullying. And certainly you can see a transition over the last few decades from a focus on targeting the bully. So saying to the bully, this isn't appropriate, and looking at punitive measures against the bully, to then focusing on the victim, so to speak, even though we don't like the term victim, of the bullying. But now actually what most of the focus is on, and from what I know about the campaign you mentioned, it's the same there. It's almost the bystanders. We're recognizing actually the power of the norm is, if somebody doesn't feel a behavior is appropriate socially, they're far less likely to do it. So within bullying interventions, the focus now is on empowering people who aren't the bully and aren't the victim, but are observers of it, so bystanders, to stand up and speak up and say that isn't appropriate. And the research shows that's a far more effective way to reduce bullying than focusing on the victim or the perpetrator.
Do you find it's also important almost for selling in behaviour change to, say, clients? Have you ever encountered any challenges selling into clients? And I suppose, how have you kind of overcome those?
If I think of one of the main barriers that I used to encounter when I first started my career, was around the time spent understanding the problem. Very often I'd go into a client, they would specify the target behavior and want me to develop a solution immediately. Whereas we know that the effectiveness of that solution increases significantly the more you know about that problem. But quite often when you're doing that work, that exploratory work, the client just, you might be doing desk-based research or might be doing interviews. They don't necessarily see the utility of it, because they just want you to deliver something, and that's the focus of it. But the way I always overcame that was by demonstrating the impact. So, I would do a piece of research. I'd say to them, okay, fine, you want me to do this quickly. just hear me out, give me the benefit of the doubt, give me a couple of weeks to do this. And then I would build that data into my intervention, deliver the intervention, evaluate it, and then show through the evaluation that the reason it had been effective was because I'd identified these 3 factors, for example. And actually, had I not done that exploratory work at the start, those 3 factors wouldn't have been identified. So the campaign wouldn't have been as effective.
In the last episode of Reframe the Future, we looked at social impact campaigns. So pharmaceutical companies and other organisations and NGOs are increasingly looking at how can they move beyond just disease awareness campaigns, how can they move beyond brand communications to, exactly your point, have much more kind of impact on social challenges, social communities. So it's just fascinating to hear that, because it really highlights this interplay that's going on between behavioural science, better understanding the communities, and therefore better being able to engage those communities, and therefore having the bigger sort of social impact that you mentioned there.
So whereas 10 years ago, the pharmaceutical industry was really looking to raise the core competencies around social media and the effective use of digital channels, now it's sort of looked as if behavioural science might be the next best practice accelerator even of core competencies for pharma and healthcare communications. Would you kind of agree with that point?
I think so. I'm not going to sit here and say that behavioural science is a silver bullet that's going to change everything, and actually you apply it and you'll see miracles. What I would say, and certainly in my experience, is it complements current activities. For example, it can inform them and increase the effectiveness. It's more so a lens at which to look through something you're doing. Everything we do has a behavioral component. There are some things that you can apply behavioral science and apply behavioral insights in really small ways, and that you wouldn't think would have an impact, but actually lead to a huge impact. And in terms of the resource that's gone into them, they can be very cheap. They can be very easy to scale up. There's plenty of examples where even providing people with SMSs increases the likelihood of them paying tax, for example, or using the power of defaults. So in countries where they've introduced a default where as an as an individual, you're automatically enrolled as an organ donor, the levels of organ donors in those countries are significantly higher, because people don't take the time to opt out. Whereas, for somebody to opt in to be an organ donor, it takes time. And so with all good intentions, there's a friction cost there. So behavioral science, I've always found, is just a useful lens. And more often than not, I'm working alongside other projects or other pieces of work, even if it's, for example, organizations or healthcare organizations developing new processes on how you deal with, how you interact with patients, etc.
Yeah, and it's interesting there that you sort of mentioned, sort of impact as well, because I think just sort of looking at measurement and in fact, actually, I suppose you touched on it quite a bit earlier, sort of talking about how, we can go further than intent. Intent isn't necessarily sort of the appropriate surrogate, I suppose, for what have you, for behaviour change. From your perspective then, how can we go sort of further with measurement to really change behaviour and prove it?
I mentioned earlier about a theory of change. So again, within my work, I would identify the behavior that they want to be changed. I'd do all the exploration, and then I would develop what we call a theory of change. So the theory of change would map out, okay, these are my end objectives. This is where I want to kind of land. This is the changes in behavior I want. And then the activities, so the interventions that I'm going to do that will lead to that. And then along with that, I would then develop what you would call like evaluation measures or success measures. And sometimes you can do that in terms of the end behavior. You can measure whether somebody is doing something different, they're taking the medication or not. Sometimes you might not be able to, but you might be able to measure the intermediate outcomes. So ideally, you want to measure changes in behavior, so the outcomes, objectives. But in instances where you can't, you can at least make sure that what you're doing is based on evidence that it's going to achieve what you want to, and make sure that it's delivered as it should be.
So just on that, in terms of, there's the short-term outputs versus the longer-term goals of behaviour change. So I think, often something that we're guilty on in the pharmaceutical industry and on the agency side of things is quite short-term campaign cycles. So, we have a campaign launch and it will go for a year and then slowly iterate. But what strikes me as being important from what you're saying is that with behavioural science, we need to really think about the long term, because that's where we're going to see behaviour start to change, where we can kind of iterate, messaging and interventions to kind of complement that journey of a behaviour change that we want to see.
I think the importance of evaluation is understanding that there are changes that you'll see in behaviour that might be more immediate. There'll be some that are long term, but actually for health, I would be asking, okay, does this behavior need to be maintained? Sometimes there's a behavior change that you actually just need to happen for a set amount of time, and that's fine. You can demonstrate it, you can show the impact. If there's long-term changes required, or you want people to maintain a behavior, I would be thinking and embedding that within the project itself. So before you kind of move off it, measures by which you can collect that data and assess if it's still working. Within COVID, with the vaccine uptake, we were so the guidance that I did on engagement was that there were 3 principles: engage to understand, so understand the problem; engage to empower, which was about co-production, co-creation, so empowering them to help their communities to change; but then engage to evaluate, because we've acknowledged, there are multiple influences on behavior, and those influences can shift. So you might design a campaign or a comms message or an intervention to address X, Y, and Z, which you've identified are influencing that behavior. But in 6 months' time, that X, Y, Z might have disappeared, and there might be 3 other influences on behavior. And you now need to tweak your campaign or your comms to address those. And so we were finding with comms that, the primary barrier for a group might be distrust. We would address that. We'd see an increase in the uptake of the vaccine, but maybe not as much as we thought. So we would do some more engagement and we'd find out, okay, there's another barrier here which we hadn't identified before. And distrust is no longer an issue, but there's still people not having it because of this new barrier. Okay, what do we do now? So that kind of iterative, agile, ongoing approach, I think, is key.
So I think from everything that you've said there, it's clear the importance of piloting, of feedback loops, and of evaluation kind of as a whole. And I think when we look at our own Acumen framework, through which we aim to plan and measure our campaigns from insight to impact, behavioural science, I think, provides a very clear, very robust framework to help us do that effectively. But also to ultimately execute patient-driven, outcomes-focused health campaigns as well.
I completely agree, Will. And for me, this has been an incredible reminder about how behavioural science really is a lens through which to look at the work we do with our clients and with the pharmaceutical industry. Whether it's improving cervical cancer screening rates, whether it's reducing stigma in society experienced by those with specific health conditions, or whether it's encouraging certain populations to access health services. Behavioural science really lies at the very heart of that and pushing and nudging populations into those healthier behaviours. Wayne, thank you so much for your time today. That's been incredibly insightful. You're clearly a true thinker and innovator in this space. So thank you ever so much for your time today, and we've been absolutely delighted to have you on the programme.
Brilliant. Thank you. Thank you for inviting me. It's been a really good, interesting conversation. You're clearly passionate about behaviour change, as am I, and I think the utility of it within the work that you're doing is quite clear. So thank you.